Hi, I'm Tom O'Connell with the Eastside Freedom Library. Welcome to the third in a series of conversations we are calling Learning from the Past, Fighting for the Future. It's pretty obvious that we're living through an era of multiple crises. The pandemic, an economic depression, racist police systems. Times are tough, but a response to crisis can inspire creative approaches that have long been considered unrealistic or simply unimaginable. When the topic of healthcare comes up, most Americans think of their personal health and how they're going to pay their healthcare bills. But this pandemic is revealing that the health of our bodies depends in many ways on a healthy body politic. And that is where social medicine comes in. What is true at the national level is even more true at the global. A globe-trotting virus demands a global response. To expand our own imagination about what is possible, I'm joined by Dr. Michael Westerhaus, who teaches social medicine at the University of Minnesota's Medical School. Dr. Westerhaus is founding member of the Social Medicine Consortium, a global partnership that combines social medicine education with community organizing to advance public health. Welcome, Michael, and thanks so much for joining us.
Great. It's great to be here. Thanks so much for the invitation, Tom.
Yeah, I'm really looking forward to this conversation. Can you tell us a little bit, just what is social medicine?
Yeah, great question. And as I hear you do the introduction about like lessons from the past, I think social medicine is something that has a deep history, often one that's not included in many medical school curricula, and one that I learned a lot about along the way. I think social medicine in general is the idea that when we look at health in society, both at an individual level and more at a communal level, we need to be looking at the ways in which social forces are affecting health inside the body. And often as medical professionals, when you use the term medicine, we're often thinking about like biomedicine, like what's going on at the cellular level, the organ level inside the body. And many of those things are heavily influenced by what is happening outside the body and society. And social medicine originally, the term kind of goes back to the mid 1800s.
Really?
When a physician by the name of Rudolf Virchow, who is a German pathologist, was sent to a area of Prussia to investigate a typhus outbreak. And he came back to the government and said, what we actually need is prosperity, full and unlimited democracy if we want to improve the life conditions in a way that addresses the typhus pandemic. So many people since that time have sort of drawn on this idea that we need to, as clinicians, we need to understand what's going on in society in ways that we can respond. Social medicine, I think, draws on the social sciences and the humanities to learn. It draws on the wisdom and knowledge in communities. It takes organizing and community building as like a central practice in it. And there are lots of different people who have kind of grabbed onto that term, social medicine. But kind of that's sort of the idea that society has an illness and a sickness in it, which needs to be addressed, not just the sort of cellular biological stuff that's going on inside the body.
Yeah. So you grew up in, is it Cold Spring, Minnesota?
Yes. Yep. Grew up in central Minnesota. Yeah.
Small community. What was your path from growing up in rural Minnesota to the University of Minnesota Medical School and then social medicine? What got you going in that direction?
Yeah, great question. Yeah, I grew up in central Minnesota. I was in a family of educators. My father was in school administration. My mom was a first grade school teacher. So I think from early on, I was very curious and interested in the world. Got interested in science fairs, the human body, ended up going to college in St. Louis thinking, I want to do a PhD in biology, and then realized I didn't want to spend my whole life in a science lab, and was really like interested in human interaction and relationships. Had a few experiences which sort of pulled me to thinking about international health, and then ended up deciding on going to medical school. The year prior to medical school, I spent a year living in a rural community in Uganda.
Oh, okay.
And there, at the time, there was, the community was being considerably afflicted by HIV and AIDS, and sort of learned from folks who are responding to that in their own community, the real importance of community-based responses. And so I came back to the US, started medical school, sort of had my traditional biomedical training, thought I was ready to tackle disease, and then headed back to northern Uganda, where I was humbled time and time again about the ways in which my training in biomedicine, in understanding what was going on in the body, was insufficient to respond to disease. And had a number of different patient interactions and lessons from social workers and community health workers and nurses, people who get that these larger social forces matter, taught me that my education had been incomplete and insufficient, and that medicines and laboratory tests were not going to be enough to respond to suffering. And then kind of in the midst of that, discovered social medicine and sort of this long history of practitioners recognizing that they needed to understand more than the body in order to sort of respond in a collective manner with other people. So, and since that time, I've kind of, that sort of gotten me into thinking about and feeling passionate about filling in those gaps in health professional training. The things that aren't taught, but that are so important to recognizing and understanding health in any community setting.
Are there courses now, or at least parts of courses, that introduce a medical student to social medicine as a concept?
There are. And I would say there have been for a while, although their importance is growing. I think particularly in this moment of COVID, a movement for Black lives really challenging all of us to recognize the need for racial justice. I think there's a lot more conversations about how do we teach health equity. Not everyone uses the term social medicine, but I think it's very much social medicine curricula. And I've been fortunate enough to be part of 10 years of classes that have been happening in Haiti, Uganda, and also here at the University of Minnesota, that really look at sort of filling in these things. The ongoing problem, I think, is they're often still relegated to an elective or something that happens in people's additional free time. It's not seen as like what needs to be part of a core curriculum to becoming a health professional, when really I think understanding health equity and social forces is as important as in understanding the genetics in the body.
So you're a practicing physician. You do work on individual bodies or assist people with their physical issues. Tell us a little bit about your practice and where do these ideas about social medicine fit in?
I practice at a refugee health clinic in St. Paul, where I've been for about almost 10 years. Have the deep privilege of learning and caring together with a group of folks who have in large part come initially to Minnesota as refugees, and have worked to sort of build life and community here in Minnesota for many, many years. In terms of what that means on a day-to-day basis, what does social medicine mean on a day-to-day basis? I think probably the most direct application is really it slows me down and reminds me constantly to pay attention to people's stories. There's a whole branch of medicine called narrative medicine, which is really that like health, disease, all of those things as humans, things play out in stories. And as medicine is practiced today, it's largely cuts people's stories out, because we're filling out our electronic medical records and making sure we have X, Y, and Z data, and we often forget to center the story of people. And so for me, clinical practice is about remembering the stories and that being a space in which we can bear witness to how social forces are impinging upon people's health. It's not often, I've learned again humbly along the way, it's not actually, the clinic setting isn't where we often change the social forces, but it's certainly where we can see the ways in which they get inside of people's bodies. And so for me, it's remembering constantly stories. It's remembering to ask about things beyond just, are you smoking or drinking alcohol? It's about remembering to ask people about who's important in your family. What's your housing situation like? Do you have readily access to food? How is language impacting your ability to get the care that you need? What are your strengths? What is your role in your community? It's just constantly remembering to think about what are all these things that affect health that are outside of the body. And then I think it's remembering how to, based on what we learn, how can we partner with people out in the community who are very knowledgeable about and already doing work on housing and food access, and how can we partner with those kinds of folks? So
I think you've begun to answer maybe my next question. I know that social medicine, and certainly your approach to it, really looks at some big systemic issues. It sounds a little bit like chapter 7 of the sociology text I used to use when I was teaching race, 7, 8, and 9. Race, class, gender, economic inequality, and a lot of the big issues and structural issues that we're really facing today, in addition to the pandemic. Oftentimes when you have that big global structural class analysis, it can be overwhelming. How do you connect action, whether in the clinic or in the community, to moving on these systemic issues?
Yeah, overwhelming is a good way to put it, because I think you start looking at, when we one of the first days when we teach social medicine, we'll often start with this like classic public health diagram, which sort of has like, it's labeled the determinants of health, and then in the center you have biology, and then behavior, and then society, and then structure. And really, when social medicine, we're looking at the outer rings. And I think for a lot of health professionals, when you start asking like, well, what are these outer rings full of? It's like, can easily become overwhelming. It's like, how am I supposed to manage these kinds of things? I'm already overwhelmed in a busy clinical practice. I think for me, a couple of things have been really important. One is we don't tackle these things alone, ever. Traditional, I think, and I'll speaking in my own role as a physician, health professional, like we're often trained, I think, to think we can tackle all the problems ourselves. I mean, there's sort of this hubris that we all have as physicians that like, oh yeah, we can do X, Y, and Z and fix everything. And things never happen on your own. So it's, again, remembering to center like partnerships when we're working on these bigger outer rings, that like, it's not my job. Might be my job as a physician to identify that housing and exposure to allergens and poor housing is the underlying cause of like repeated asthma exacerbations. But it's certainly not my job alone to work on like changing some of the things that are creating how like people being forced into living in those situations. There are lots of community organizers, housing advocates, people who we can partner with to be able to do that work. The other thing is, I think for me, recognizing those larger structures and being honest about them, it feels like it creates a little bit more of a daily integrity in the work I'm doing, though. I think if we, as clinicians, are constantly thinking that we can fix problems in the clinic, I think all of us know that there's a little dishonesty in that. And even though we might not be honest about like recognizing that on a daily basis, it creates an unease within ourselves that, hey, we're not really being like, we're not going to fix some of these underlying problems unless we recognize that these larger forces are at play.
Mhm.
So for me, even though it's hard and overwhelming, it feels like I'm being a little bit more authentic when I'm acknowledging how important those things are, and then
Mhm.
finding ways with other health professionals and other folks who are doing work out in the community, effective ways to build relationships and organize to respond to those. It feels like yeah, there's an integrity to it, I
Mhm.
think.
You
So,
know, there's such a discussion now, and there has been over the decades, but once again, at the forefront about racial inequities and systemic
mhm.
racism in really all our institutions, including medicine. Is social medicine both as an idea and also as a network or field or group of people? How do you feel you're dealing with that? And it is one place we might look for. Here's some folks that are really on top of it, or is it and not or but and or is it a continuing struggle?
Mm. Yep. Yeah, I think, well, one of the other things that I think has been really important for our group, the Social Medicine Consortium, who have been doing this work, is recognition of how important it is to um, make this work personal and very self-reflective. And I wouldn't say, if you look at the history of social medicine, that that's always been part of it.
Mm.
But I think for all of us who are involved in this global movement, it's really important for us to, one, stop and look at like our own profession, like medicine. If we're going to talk about like structural racism, capitalism, patriarchy, settler colonialism being really driving forces in health disparities, we need to stop and look at like, how is medicine part of that? And then even at a more personal level, how am I, like
Mm.
Westerhaus, on a day-to-day basis, part of that in my practice? And around the issue of structural racism, medicine has a very, very long history of playing a really fundamental role in racism and ideologies of racism in society, because of the ways in which you know, we've kind of baked in race-based medicine into what we do. And an example that I would give is, you look at things like spirometry, like tape breathing and finding out like how much space do people have in their lungs. Or if you look at like kidney function, estimate the lab-based testing around like kidney function, how well are people's kidneys functioning?
Mm.
Those both have adjustments which are made based on race
Mm.
built into them, which, if you do a historical deep dive and look back at, really have no solid evidence for why we do that. And when
Hmm.
we do make those corrections, it actually ends up affecting who gets care and who doesn't get care. It might make the difference between whether you qualify for a kidney transplant or not.
Hmm.
And so a lot of us involved in this social medicine work right now are first saying, hey, race is a social construction, not a biological construction, as we've been teaching in medicine for many years, that there is like a biological basis to race. We need to actually undo that. And we need to do a deep dive into the ways we're teaching that, and
Hmm.
name that it's a social construct, and find ways to get rid of that.
Yeah.
I think it's also naming that racism, not race, is the cause of health inequities.
Mhm.
And so there are a lot of folks who have been leading us and mentoring us in the consortium to kind of do this kind of work, organize like in our medical schools, and say like, we need to stop, we need to really look at how we are practicing race-based medicine, and really root it out.
Yeah.
So
I think many people would be surprised. I am that there have been, or not have been, because I thought this was in somewhere back in history, that there's actually specific physical conditions or organs like the kidneys that have a racial
mhm.
definition or man.
Right. Yeah. And same for me, 5 years ago, I did that adjustment for years. And then all of a sudden, people are saying, hey, why are we doing this? And
Mm.
actually there's no data that would support this. And it actually is causing disparities in health outcomes. So
Yeah.
yeah. And then, and then on a daily basis too, it's for me to look at, I'm a white male physician.
Mm-hmm.
Most of my patients are refugees, are people of color from other countries. Like, what are the ways in which I also
Mm-hmm.
have breathed the air of racism into how I practice and how I make assumptions about what's offered to people and not offered to people? And what are the ways I can pause and slow myself down,
Mm-hmm.
name those assumptions, try and become aware as much as possible of those implicit biases, and then hold myself accountable
Mm-hmm.
in our clinic and in our community to taking steps to change that.
Yeah. Switching a little bit to the global perspective, which social medicine is involved with, and you certainly have been. How do you see the significance of President Trump's withdrawal from the World Health Organization?
Yeah, I mean, I think the U.S. pulling out of the World Health Organization is certainly consistent with what we've been hearing over the last 3 to 4 years about America first, really this idea of like America can go at it alone, and that somehow we are being held back
Mm-hmm.
by what other countries are slowing us down from doing. And I think the pandemic is a perfect opportunity for us to look at how interconnected the world is
Mm-hmm.
and how important it is for us to not be severing relationships, but to really be deepening relationships.
Mm-hmm.
Now, a lot of the interconnections that the world has now, and I think this is certainly relevant for health when we think about like social medicine and diving back into history. I mean, a lot of the relationships that have been built in the world were built on slavery, they were built on capital flows, they were built on power inequities in the world. And I think we as a country have profited like massively based on sort of those histories.
Mm-hmm.
So to now pull out
Mm-hmm.
at a time when we're seeing COVID move, along those capital flows and again settle into the most vulnerable communities is again, it's consistent with sort of this ideology we've been hearing about America first, but I think it's another way that we're not sort of stepping up and playing our role and saying we're in an interconnected world now.
Mm-hmm.
We have a great amount of repair to do. There's a lot we can learn from community building, idea exchange.
Mm-hmm.
And so that leaves us as a country isolated, facing really the most raging outbreak of COVID,
Mm-hmm.
with a very uncoordinated, non-public health response. So it's unfortunate. I think we all lose out as a country in deep ways.
Yeah.
In deep ways, not only now in this moment, but that are going to last far into the future.
Yeah.
Because there's places that have been really model
Mm-hmm.
for how to respond to coronavirus.
Yeah, I wanted to ask you about that, and you've worked in some of those places. The usual paradigm, and again, President Trump articulated this in a way that I think, unfortunately, many Americans believe. This idea that, particularly in the global South or developing countries with less wealth overall in the United States, they are. I mean, he's referred to them as, I don't know if I can say it here on the internet. I know I couldn't say it on the radio. First word starts with an S, the last word is whole. Countries. And really, we have nothing to learn from them. We may use our hardworking Americans' money in foreign aid and help them, but we have nothing to learn from them. But you say there's a lot of things we can learn from the way folks approach health issues. Can you talk about that a little bit?
Yeah. Yep. Yeah. I mean, it's really it's a tragedy that we have closed down opportunities to learn from those places. And I've through the social medicine work, places that I've had a particular opportunity to spend more prolonged time are Uganda and Rwanda. And there are many other places where I think you could also do a lot of learning. I'm mentioning those just because I'm more familiar with them. And, both of those right now are both countries, if we're going to sort of look at like COVID response, at this point, both countries have less than 100 deaths due to COVID. They are countries that have, in some ways, I think we might look at them and say they are very underfunded, disorganized health systems. But I think what COVID is currently showing us, like in Uganda, where I know best, they've had nine deaths, nine recorded deaths from COVID. I think 1,000 some cases. And you know what? It's true in Uganda, they don't have lots of ICUs and like ventilators and the kinds of things that we think about that are so necessary for a response to COVID. But what they do have is, and Rwanda has this as well, probably even to a greater extent, a fairly strong public health system. In Rwanda, they have a community health worker system where every single village has a community health worker.
Really?
Who is someone whose job is to be aware of what's going on in the community, a health resource, and someone who, if something is amiss, people go to. It's a trusted member that the community elected to sort of be their health delegate. And they are working right alongside physicians, nurses. They are as important as those other members of the health system. So you have a very coordinated system that has tried to chip away at some of the hierarchy that we have in our health system. And what is that? It's not really a surprise that you see a much more coordinated response. Like somebody has COVID or symptoms of COVID in the community, people all know, people are quickly brought to like the right care, and you quickly shut down the transmission in the community. Another place where I have a little bit of familiar with their educational system is Cuba. Cuba's also have a fairly robust response to COVID. When I visited there to learn about their medical education system, I was talking to third and fourth year medical students who had visited thousands of homes. They had done thousands of home visits as part of their medical training because their delivery of primary care is so rooted in the community. When I went through my training, I probably had 3, 4, 5 home visits that I did. So again, systems of care that are not rooted in clinics and hospitals, but are out in the community, have been far more successful in responding to the epidemic because people have relationships, they have public health systems of surveillance, they have, they don't have super expensive healthcare systems where all the money is being dumped into tertiary care, but they're really slowing things down on the front end. So yeah, there's a lot of learning we could be doing about ways we could be structuring our health system differently with really like a robust system of community health workers. I think like right now, if we've got a lot of unemployment, including health workers, like what if we just developed like a robust community health system where we've got people doing contact tracing and like, and that's much lower cost than paying for everyone to show up in the ICUs when they're sick from end stage COVID. So lots of learning we could be doing that, could be fiscally smart, but also would be community smart in terms of ways we're engaging and building relationships.
I don't want to belabor too much the current political leadership or lack of leadership. I guess I am. How are you how are you feeling, thinking about the really negative response in many places, from the president down to many governors and then community folks, still not even recognizing the reality of a pandemic or actively resisting efforts to mitigate, including community tracers, which you just mentioned. That must really bum you out. I mean, how do you think about that, and how do you cope with that?
Yeah, I mean, it does. It's a tough time. I mean, for all of us, and I think certainly in the health professions, when I have the fortune of being connected to a global network of people where I feel like there is significant innovation and response happening. And then to see here in our own communities, it feels like in some ways we've gotten to the fatalistic or pessimistic point of like, well, we're just going to wait around until we have a vaccine.
Yeah.
And, we're just, whatever happens between now and then, which again, a vaccine is going to be very helpful and effective. Hopefully, again, it's consistent with a biomedical response, which I'm fully supportive, but there are so many other things that should be going along with that. It is deeply troubling to see how even something as straightforward and simple as wearing a mask has generated and this sort of political divisiveness, or plays on the political divisiveness that we are facing as a country. And I think there are just so many historical lessons we could be looking at other pandemics or other places in the world right now that don't require us to even innovate or come up with new ideas. It's just putting into place tried and true public health responses. And the milieu of things in our society right now, I think individualism, the political divisiveness, this greater lack of sense of a common good, that you're not just putting on a mask for yourself, but you're putting it on for the health of others. It's like, it's not something that we readily embrace, which is, again, points to like the social like the work we have to do is not as much the work in the clinic or the hospitals if we want a healthy nation. It's like all the larger set of social values that we have, the decisions that we've made and the consequences that we're paying for them right now. I know one thing we haven't touched on much is just thinking about the deep impact of like neoliberalism and capitalism, and neoliberalism being really this strong ideology that emerged in the mid 70s and then with the Reagan administration in the 80s, which is really like privatization is the way to go. We reduce social spending, we reduce public spending. Privatization and the free market will innovate, will solve all of our solutions. And the unfortunate thing is that exacerbates inequities. It doesn't always lead to the best innovation, and it leaves us with social services and responses that are massively underfunded. And so, suddenly you throw a pandemic on that, and we don't have the coordination, we don't have the funding, and we certainly don't have as a society the cognitive analysis that we need to be paying attention to those who have been consistently left out, because those are the people that are going to face COVID the most. So it leaves us where we are. And it leaves us kind of hoping that hopefully in 6 months we're going to have a vaccine that'll sort of magically take care of this, but we have a lot of work to do. A lot of work to do. And thankful, and the racial justice with George Floyd's murder comes into that mix. And thankfully we've got a group of like thinkers and leaders in the movement for Black lives who again have lots of wisdom from that has grown up over years of racial injustice. And I mean, again, if we can just turn and listen and think about ways we can imagine our society in other ways that is actually good for all of us, we'd be moving in the right direction.
Yeah, that's a perfect segue into my final question, and kind of the theme of this series, which is oftentimes in eras of recession, depression, political, social crisis, ideas do emerge that are positive, practices emerge that are positive, that carry us forward. And not to be Pollyanna about it, because looking at the country and the world right now, it's difficult to be Pollyannish. Are there some ideas, movements, projects, developments that you think really are emerging that are positive and that can carry us forward?
Mm. Yeah. Yeah, certainly the instability of the moment, things crack open and you see some amazing things move forward that you might not have expected otherwise. There are many really hopeful, inspiring collectives of people who are coming together and I think really dreaming about a better world. My experience is most tied to a movement called the Campaign Against Racism, which came out of the work of a physician by the name of Dr. Kamara Jones. And she is a family medicine physician who trained in a program with the title Social Medicine in it in New York City. And eventually she became the president of the American Public Health Association. And she has written and told stories for many years about how we think about the impact of racism on healthcare, and has used allegory and some really interesting ways to talk about how we can think about racism's impact. And a couple of years ago, as the president of the American Public Health Association, Kamara Jones launched sort of a global campaign against racism. And as our organization was in its infancy developing, she asked us to sort of take on the global dynamic, the global component of the campaign against racism. And so we have, for the last 3-4 years, had a group of chapters organizing in their own local communities around sort of what are the ways in which racism impacts health. And largely these are groups of health professionals. We have a chapter in Haiti, Uganda, Palestine. We have one in the Navajo Nation. We've got a number of, we have one here in the Twin Cities. And thankfully, I think the work we all were doing in the early years of the campaign, learning about community organizing and building the important relationships, prepared us now to take this particular moment to advance racial justice work, I think, within our own institutions, whether that's our medical education institutions, whether it's our health delivery institutions. And so you have groups who are actively, in the last 6 months, there is a group at Vanderbilt University who are part of this campaign against racism, who got the institution to eliminate that adjustment to kidney function that was being done on race. It's gone. You just get rid of it. And there are, here in the Twin Cities, our group has chosen to focus on the linkages between incarceration, racism, and homelessness. And we've been working with there are probably about 15 of us who are health professional educators, social scientists, who have been working with housing justice organizations to show up and support their work. We've been working with a really interesting organization called the Zamya Theater Group, who are a group who uses something called Theater of the Oppressed, which is comes from Augusto Boal in Brazil. And it's a group of people who are either formerly or currently homeless here in the Twin Cities, who use Theater of the Oppressed to try and work on changing the narrative of homelessness here in the Twin Cities. And so we've been fortunate enough to work with them, both to learn from them. They facilitated some theatrical presentations with health professionals to get us thinking critically about how do we reproduce harmful narratives around homelessness in our own health care, education, and practices. And now we're kind of collectively designing what we're calling some solidarity workshops, where we're creating some scenarios that can utilize Theater of the Oppressed to kind of then invite health professionals to come into these spaces, into our workshops, and really think critically about, like, how is my institution need to reframe how we talk about homelessness, because we're actually being very harmful in the ways that we're doing it. So this moment gives us a lot of energy. It gives us a moment to really organize ourselves more thoughtfully and continue to build power together with communities and let communities lead based on their own strengths and wisdom from their lived experience of injustices that they faced for many, many years, and ask them, how can we show up and support what you're doing?
Great.
So there is lots of encouraging things that can be happening that keep me hopeful in this moment.
That's
as
great.
well.
Well, thank you very much, Michael Westerhaus, for joining us. I've learned a lot, and I'm feeling hopeful. I'm glad you are. If folks want to learn more, is there any, like, just Google social medicine? You mentioned some organizations. Do you have any just quick advice for how people can find out more?
Yeah. Probably the organization Equal Health. So the Social Medicine Consortium recently had this kind of merger of a number of different organizations and entities coming together, and that all falls under Equal Health now. So equalhealth.org,
Okay.
which includes the consortium and the campaign against racism and a number of other social medicine opportunities.
Okay.
We have an upcoming conference
Oh.
in October, which can be a deeper dive on any of these various elements, whether it's education you're interested in, or it's movement building around the campaign against racism, or you're interested in learning about what's happening in Uganda and Rwanda or in Haiti, is one that I'm most closely tied to. There's also an organization for those who are health professionals. There's an organization, Minnesota Doctors for Health Equity, which is a group who's organizing around physicians in particular to kind of show up and work for legislative and policy changes here in Minnesota that has a social medicine and a health equity lens sort of undergirding it. So those are a couple of local organizations.
Great.
And then I will mention Zamya Theater Group again is one that's doing community work.
Okay. Is it could you?
Zamya, yeah, it's Zamya. And they have a beautiful website. They're doing a lot of really important work around homelessness and equity. And then the other one I'll mention, partly because it's just foundational when we teach about social medicine, is an organization that offers sacred sites tours. And this is partly run by a guy by the name of Jim Bear Jacobs, who is a indigenous storyteller and a guy who works a lot around racial justice. And he offers an extremely powerful tour of Badote and sort of talks people through the history of white settlement and really genocide here in Minnesota. And that's really often a starting place for us when we talk about social medicine. Like if we're gonna look at the lay of how these bigger structures were set in motion here, we need to like do our proper homework historically. And Jim Bear Jacobs and his Sacred Sites Tour are extremely powerful opportunities to sort of dive into that history. So,
that's great.
Yeah.
Well, thanks again for joining us, and thanks as well for all of your ideas about resources. And I've got several ideas that I think I'm going to share with staff here about programming at the Eastside Freedom Library. It's some great ways that we can kind of continue the dialogue and continue the conversation. So thanks for joining us. I really look forward to seeing you some more and working together as we move forward. That was, yeah.
Likewise. Yep. Very grateful for all the work the library is doing just to continue to create a space for collective envisioning of futures together with the community. So, yeah.
Thank you. All the best. So each episode of this series opens on the last Monday of the month from 7 to 8 Central Standard Time, and then is archived on the Eastside Freedom Library Facebook site and YouTube channel. For information on the full range of programs here at the Eastside Freedom Library, go to our website, www.eastsidefreedomlibrary.org. Thanks for tuning in, and until next time, please do take care of each other.